Hi, my name is Frida Wimsat, and I'm going to talk to you about Chapter 10, the assessment of high-risk pregnancies. First of all, this chapter concentrates on the testing that is done for high-risk pregnancies rather than for those that are considered routine. And the antepartum testing has two major goals. The first goal is to identify fetuses at risk for injury due to interrupted oxygenation that could cause permanent injury or death. And then the second goal is to actually identify appropriately oxygenated fetuses so that we can avoid unnecessary interventions. In most cases, monitoring begins between 32 and 34 weeks of gestation, and it will continue regularly until birth. Assessments of risk factors. There's the biophysical risk, factors that originate within the mother and the fetus and affects the development of the functioning of either one or both. And that would also include defective genes, transmissible inherited disorders or chromosomal abnormalities, multiple gestation, macrosomic infants or ABO incompatibility, as well as the nutritional status. And then psychosocial risk, maternal behaviors and adverse lifestyles. Social demographic risk arise from the mother and her family, and environmental risk. We just talked about the genetic disorders, and let's talk about the nutritional status. The nutritional status would be conditions that influence nutritional status include a woman of very young age, like prepubescent age, where she herself requires lots of calories, 3 pregnancies within the previous 2 years, tobacco, alcohol, or drug use, inadequate dietary intake because of chronic illnesses or food fads, or inadequate or excessive weight gain, and also a hematocrit value of less than 33%. Medical and obstetrical related illnesses such as poorly controlled diabetes mellitus and hypertensive disorders as well. Assessment of risk factors for psychosocial risk, and that would include like smoking, because smoking includes a low birth weight infants, higher neonatal mortality rates, increased rates of miscarriages, and also increased incidence of premature rupture of membranes. Caffeine intake, pregnancy or pregnant women who consume more than 200 milligrams of caffeine daily, which would be equivalent to about 12 ounces of coffee per day, may be at increased risk for intrauterine growth restriction. Alcohol, that could cause fetal alcohol syndrome, fetal alcohol effects, learning disabilities, and hyperactivity. Drugs, this can be tetragenic, cause metabolic disturbances, poor chemical effects, or cause depression or alteration in the central nervous system function. And this category includes medications prescribed by the healthcare provider or bought over the counter, and even the herbs and supplements, commonly abused drugs such as heroin, cocaine, and marijuana. And then the psychological status of a relationship between an emotional distress and birth complications. And this risk factor includes conditions such as specific intra-psychic disturbances and addictive lifestyles, a history of child abuse or intimate partner violence, and of course, inadequate support systems. And then there's the social demographic risk. That includes low income, lack of prenatal care, the fact that a woman does not have prenatal care, well, that prevents early diagnosis and treatment of possible complications, and a major risk factor arising from financial barriers or lack of access to health care. Age is a factor. The younger the person is, the more at risk for anemia, preeclampsia, prolonged labor, a contracted pelvis, or cephalopelvic disproportion. And then with the older women giving birth, that would be conditions more likely to experience cesarean births, preeclampsia, hypertension, diabetes, prolonged labor, placenta previa, placental abruption, and death. Her fetus is at greater risk for low birth weight or macrosomia related to diabetes, and chromosomal abnormalities or congenital malformations, and even neonatal death. And the parity, so women who are giving birth for the first time, nulliparous, they have an incidence of preeclampsia and dystocia. And then marital status, of course, that plays that plays into it. Including the increased risk for preeclampsia, are often related to inadequate prenatal care and a young childbearing age. So, and then ethnicity plays into it because African American women have the highest rates of preterm birth, almost twice as high as those of other racial and ethnic groups. Environmental factors, hazards in the workplace such as chemicals, anesthetic gases, radiation, all of those industrial pollutants, cigarette smoke, stress, and diet can inadvertently be a tetragen for the unborn. And also the father plays a role because his exposure to mutagenic agents in the workplace has also been associated with increased risk for miscarriages. Psychological considerations. Label of a high-risk pregnancy may result in increased sense of vulnerability and stress related to the diagnosis. There's already ambivalence regarding the pregnancy for a normal pregnancy, but it's even worse if you find out that there might be some possible abnormalities. Inability to accomplish the task of parenthood, and fearful for well-being of the mother and the baby. The first test that we're going to talk about is the daily fetal movement count, abbreviated as DFMC. It used to be called daily kit counts, but the daily fetal movement count is very simple, yet the method to evaluate the condition of the fetus. And that is, the mother lies still. She will have something to eat or to drink, and she will lie still with her feet propped up, very relaxed, and count the times she feels her baby moving, okay? And several methods can be used to do this, and it's usually at about 16 to 20 weeks that she's able to do that, to feel fetal kit counts. So she can do it once a day for 60 minutes. She can do it 2 to 3 times daily after meals and before bedtime. And the key is that 10 movements in a 12-hour period is really what we're kind of looking for. But the danger is if there's no movements at all within a 12-hour period. Now, fetal movements are usually not present during the fetal sleep cycle, and that's about 20 minutes out of an hour or something like that. It may be reduced if the mother is taking depressant medications, drinking alcohol, or smoking a cigarette. And movements do not decrease as the woman nears term. That's just a folklore. And then obesity can decrease the perception of the fetal movement and consequently the ability of the mother to give an adequate fetal kit count. Here again, this is a graph where she can write down how many movements she felt within a particular time period. And if no movements are felt for 12 hours, she needs to notify the physician right away because that is a fetal alarm signal that there is a problem. Biophysical assessments. So the levels of ultrasounds. First of all, ultrasound is a diagnostic ultrasonography is an important safe technique in the antepartum fetal surveillance. What happens is sound is a form of wave energy that causes small particles in a medium to oscillate. And the frequency of sound, which refers to the number of peaks or waves that move over a given point per time. And that is expressed in hertz. So sounds with frequency of 1 cycle or more peak per second have a frequency of 1 hertz. And when directional beams of a sound strike an object, an echo is returned. So the time delay between the emission of the sound and the return and direction of the echo is noted. And from this data, the distance and location of an object can actually be calculated. So ultrasound is sound frequency higher than that detectable by humans. And ultrasound images are a reflection of the strength of the sending beam and the strength of the returning echo and the density of the medium, whether it be muscle, such as the uterus, bone or tissues such as the placenta, fluid, or blood, through which that beam is sent and, of course, returned. There are levels of ultrasonography, and they are called the standard. The standard is the basic examination And it will determine the amniotic fluid index, and that's the amount of amniotic fluid around several pockets around the woman's umbilicus, the baby's presentation, cardiac activity, and placental position. And the ultrasonographer can do this, a nurse, or a healthcare provider. A limited ultrasound is to detect specific information. So we've already detected that there's a problem. Maybe there's slow descent or there's failure to descent, and we need to figure out what the fetal presentation is. Maybe it is asymptotically. A healthcare provider needs to do a limited ultrasound. And then with a specialized ultrasound, that is very detailed or targeted examination because they are very suspicious that there is a problem with a anatomically or physiological abnormality with the fetus, such as spinal tube defect or hydrocephalus or something of that nature. And so those specialized ultrasounds are performed by highly trained and experienced personnel. Indications for use. First of all, we can pick up the fetal heart rate activity at about 6 weeks gestation using a transvaginal ultrasound. And a transvaginal ultrasound is one where the probe actually goes towards the vagina and it is covered with a sheath or a condom, and it can actually see through the cervix into the uterus. And then there's a gestational age that is determined by measuring the fetus's crown, rump length, the biparameter diameter, the head and the abdominal circumferences, and the fetal length in the first trimester. Now, after 22 weeks, though, the ultrasound dating is less reliable due to the fetal size. But before then, it is more reliable than the Nigel's rule for gestational age assessment. And then the fetal growth, that would be measured by serial ultrasounds of the biparameter diameter, limb length, and abdominal circumferences. The fetal anatomy, head and the ventricles and the veins, they can detect hydrocephalus, for example. Here is a ultrasound picture depicting the head circumference and the abdominal circumference using an abdominal ultrasound. Biophysical assessments, fetal genetic disorders, and fetal anomalies. Of course, ultrasounds can detect this. One of the new tests that they have is called the Nuchal Translucency, and it measures the fluid in the nape of the neck, the fetal neck, between 10 and 14 weeks gestation to identify possible fetal abnormalities. The fluid collection, if it's greater than 3 millimeters, it is considered abnormal. And when combined with abnormal maternal serum markers, it indicates increased risk for trisomies such as 13, 18, and 21. Now, an elevated nuchal translucency alone is risk for congenital heart defect. So if they have normal maternal serum markers, then it's congenital heart defect. Trisomy 21, the indicators include an absent nasal bridge, shortened femur or humerus, echogenic intracardiac focus, echogenic bowel, pylectasis, where there's an enlargement of the renal pelvis, bradycardia or tachycardia. Here's a picture here of nuchal translucency, and you can see right there where the fluid right here is at the nape of the neck, how it is greater than 3 millimeters there. And you can also see here where there's the detection of the nasal bridge there, where it's flat. Biophysical assessment, placental position and function. So ultrasounds are used a lot to determine information about the placenta and whether or not the placenta is functioning, as you can imagine, because that's that temporary organ that determines the oxygenation of the fetus. So the placental previa, which is a condition where the placenta covers the internal cervical os, that of course can be detected. And in most cases, the placenta previa diagnosis during the second trimester will resolve by term, because the elongation of the lower uterine segment as pregnancy advances will move the placenta up and away from the cervical os over to a low lying right around in the isthmus of the uterus versus covering the cervical os. And then a globular placenta with a narrow base in comparison with its height causes an increased risk for intrauterine growth restriction, fetal death, or other complications. Biophysical assessment ultrasound adjunct to other invasive tests. Of course, they use ultrasound in order to conduct an amniocentesis. And that, of course, has been very beneficial because the fetus and the fluid and the umbilical cord are easily identified, and it decreases the risk for fetal maternal hemorrhaging. Percutaneous umbilical blood sampling, that's another test where we use ultrasound to assist with. And that, of course, gives this type of test, percutaneous or PUBS, gives the examiner direct access to the fetal circulation around about the second and the third trimesters. But that is largely being replaced with the DNA test, and we'll talk about that in just a moment. So there's the chorionic villus, which will identify the cord, and the chorion fundusum, okay, which is a portion of the placenta located at the site of the implantation. Biophysical assessment, fetal well-being. The tests that will determine fetal well-being are sort of like the amniotic fluid volume, vascular waveforms of fetal circulation, such as the Doppler blood flow analysis, and heart motion, fetal breathing movements, fetal urine production, and fetal head and limb movements, such as with the biophysical profile. Now, the Doppler blood flow analysis. The Doppler blood flow analysis is a systolic and diastolic flow ratios and resistance indices to estimate flow in various arteries. So they're looking at the arteries here, and they're determining how that blood flow is through those arteries, whether or not it is occluded, or if it's fast, or if it's too slow, and it provides an indication of fetal adaptation and fetal reserve. So the fetal umbilical and middle cerebral arteries and maternal uterine arteries are the arteries that are mostly assessed. For intrauterine growth restriction, several restrictions of an umbilical artery blood flow during diastole, okay, can occur. So if we're looking at intrauterine growth restriction, they typically will see several restrictions of that umbilical artery blood flow during diastole. And then severe fetal anemia is an increased peak systolic velocity in the middle cerebral artery. Here, of course, is a color Doppler of the umbilical artery, and on the left side, and you see the pulse Doppler on the right. Biophysical assessment, amniotic fluid volume. With amniotic fluid volume, the sonographer can affect the results. So, for instance, if the sonographer applies heavy pressure during an ultrasound, the measurements of the amniotic fluid volume are going to measure very low. If the sonographer applies light pressure, then the amniotic fluid volume may measure a little bit higher than normal. The word oligohydramnios means a small amount of amniotic fluid. So the maximum vertical pocket is actually less than 1 to 2 centimeters. And that would be an indication of renogenesis, agenesis, where the baby would be lacking a kidney. Polyhydramnios, because amniotic fluid, after all, is the fetal urine after a certain point of gestation. It is the fetal urine that we are measuring. Polyhydramnios or hydramnios, they both mean the same things, which is an excessive amount of amniotic fluid. So the pockets of amniotic fluid measures more than 8 centimeters. And this would be an indication of a central nervous system or gastrointestinal disorder. The AFI is an amniotic fluid index, and it measures the vertical depth in centimeters of the largest pocket of amniotic fluid in all 4 maternal quadrants. So they're not just going to look at all of the pockets around her umbilical area. They're going to look at the largest pocket and measure that one. An AFI oligo is less than 5 centimeters, and an AFI hydramnios is 25 centimeters or more. Let's look at this case discussion. Okay, so we have a married Native American female who's 25 years old. She's 32 weeks gestation, gravida 2, para 1, which means she's been pregnant twice. This current pregnancy is one of them. She's given birth one time. It was a term pregnancy, and preterm 0, abortion 0, and she has one child living, and she's carrying her second one now. Her blood type is B positive, so she's not going to need RhoGAM, and she's rubella immune, so she won't need a rubella vaccine. She had a prior C-section with a low transverse incision, skin and uterus for cephalic pelvic disproportion and failure to descend. The point here is that she had a low transverse incision of her skin and her uterus. They were both cut along the grains of the uterine fibers. She has a history of gestational diabetes with previous pregnancy, which could have been the indication for the macrosomic infant, which caused the cephalic pelvic disproportion. Her fundal height measurements are 35 centimeters. Her weight gain is 2.2 pounds per week. Difficult to perform Leopold's maneuvers on her because of the excess weight gain. And abdomen is taut but non-tender. So her bowel sounds are muffled but present in all 4 quadrants. Evaluated in the physician's office for the second trimester ultrasound for an AFI. And the questions are, what type of ultrasound is going to be performed? And the second question is, what is the expected outcome based on the client's history? First of all, because we have all of these complications going on, she's going to have a limited ultrasound because we're already suspecting that there is a problem. Her fundal height measures 35 centimeters, which is greater than 2 centimeters above her gestation in weeks, which means that she probably either has twins or that she has a large baby yet again. And then her amniotic fluid is greater than 25, which means that that's also an indication, polyhydramnios is an indication of gestational diabetes, which could lead also to a macrosomic infant. And there you go, and it's due to gestational diabetes. Biophysical assessment, biophysical profile. The biophysical profile reflects current central nervous system status, and usually what happens is after a failed non-stress test or a non-reactive non-stress test, they will go ahead and do a biophysical profile. Or if the woman has a positive contraction stress test, they will go ahead and do a biophysical profile so that we can get a better indication of the fetal health. Non-invasive assessment of amniotic fluid volume, where they're measuring the placenta functioning for long term, because amniotic fluid volume gives us an indication of how well the placenta has been functioning over a long period of time. The FBM means fetal breathing movements, so we can determine if the baby's actually breathing. Fetal movements such as the trunk and the limb. Okay, so we're looking at gross movements and fine movements, and then fetal tone, whether there's active extension and flexion, and then the fetal heart rate reactivity, that would be the non-stress test, fetal vital signs, and what we conclude is that if the results are 8 to 10, and each one of those would be measured as 0, 1, or 2, and or 0 or 2, none or 2, and if the score is 8 to 10, we consider it normal, and we would just continue to watch the mom with a non-stress test. If the score is 4 to 6, that's suspected chronic asphyxia, so we consider delivery at that point, or at least induction. And then 0 to 2, strongly suspected chronic asphyxia, and that's an automatic C-section. With biophysical assessment, modified biophysical profile, it shortens the time testing because you can imagine it takes a long time to measure all of those parameters. The non-stress test and measurements of the deepest pocket of the fluid surrounding the maternal umbilical cord. So we measure the AFI instead of the AFV. The reactive non-stress test and amniotic fluid is more than 2 centimeters. The biophysical assessment nursing role. The counsel and the education about the procedure is basically what you're going to do is provide education, because that's what nurses do. Non-medical ultrasounds is what nurses could do, like 3D or 4D images. They are strongly discouraged because what would happen if you found an abnormality? How do you go about explaining that to the parent? And you do have to say something pretty much to the physician if an abnormality, of course, is found. And that's one of the reasons why these are discouraged. But however, they are also almost demanded now by the public. Biophysical assessments, MRIs, magnetic resonance imaging. They're rarely used. Biochemical assessments, amniocentesis, maternal complications. With an amniocentesis, the maternal complications could be hemorrhage, fetal maternal hemorrhage, infection. We could actually start labor. There could be an abruption of the placenta, damage to the mom's intestines or the bladder if the needle hits those organs instead of the uterus, and amniotic fluid embolism, which could be an obstetrical emergency and also cause death because it's basically a PE because of the amniotic fluid actually going through the circulation and dislodging into the lungs. And you can imagine amniotic fluid doesn't just contain fluid, it contains fetal urine, it could contain meconium, it contains lanugo, fetal hair, and also vernix, which is a cheesy-like substance that keeps the baby's body nice and supple. Here is an amniocentesis diagram. They use the amniocentesis and they send off the fluid there to determine all sorts of metabolic profiles, as you can imagine. So the fetal complications would be death, hemorrhage, infection, amniitis, where there's inflammation of the amniotic sac, injury from the needle. Risk may be minimized by using ultrasound to detect the procedure. I've never seen anyone, heard of anyone, or even thought of anyone doing an amniocentesis without an ultrasound to guide them, as well as two physicians usually are doing this. One is doing the ultrasound and one is actually performing the amniocentesis. And the indications for use would be genetic concerns like women over 35, family history of chromosomal abnormalities is what they're looking for, fetal maturity mainly for the LS and the AS ratios, and fetal hemolytic disease if they would have to go in and actually do a fetal transfusion because of an RH incompatibility. There's the chorionic villus sampling. Here is where earlier diagnosis and rapid results can occur because they're actually going in and taking a sample of the chorion here in the chorionic villus space to determine, and it's usually between 10 to 13 weeks of gestation, a removal of a small tissue specimen from the fetal portion of the placenta. The chorionic villa originates in the zygote, and the tissue reflects genetic makeup of the fetus. They would do this to detect genetic abnormalities very early on so that they could determine whether or not they were going to terminate the pregnancy as a result of it. This is what it looks like. This one here is actually the technique for percutaneous umbilical blood sampling, which is what we're going to talk about next, which is called the PUBS. And the percutaneous umbilical blood sampling, or the PUBS, gives us direct access to fetal circulation. There's an insertion of the needle directly into the fetal umbilical vessel under ultrasound guidance or intrahepatic vein. The bleeding from the cord puncture site is a common complication, and in many centers this has been replaced by the placental biopsy, which is a lot safer and easier and faster, and also the DNA can be used instead of the fetal blood. Here is the percutaneous umbilical blood sampling again. And here's a picture of the umbilical cord seen on ultrasound at 26 weeks gestation. You can see how it has one vein and two arteries. The biochemical assessment maternal assay, that is alpha fetal protein, and it is abbreviated as AFP. The maternal serum levels, and this is a blood test of the mom, a screen for neurotube defects, basically, is reliable between the weeks of 15 and 20 weeks gestation. It rules out folic acid deficiencies, anti-seizure medications, and pregestational diabetes. All of those could be indicators that we need to look out for a possible neurotube defect, such as spina bifida, hydrocephalus, and anencephalic, where the baby would be born without a brain. 80 to 85% of open neurotube defects and abdominal wall defects, such as gastroschisis, can be detected very early, and it is recommended for all pregnant women to have the AFP. The maternal assay multiple marker screeners, that's an increased risk for trisomy 21 if the person has a low maternal serum alpha fetoprotein and unconjugated esterols with a high human chorionic gonadotropin levels at about 16 to 18 weeks, and that would be increased risk for Down syndrome. The Coombs test. So the Coombs test is a blood test that determines whether or not there are maternal antibodies against the fetal positive red blood cells. And it's an indication of Rh incompatibility. So we look at them because there's two types. There's the direct Coombs test and there's the indirect. The direct Coombs test is on the baby's cord blood, and you can determine that direct because the letter D is next to the letter B. I learned that during a review of ATI. And then the indirect maternal serum is because the I is closer to the M, then that's the mother's serum. And it detects other antibodies for incompatibility with maternal antigens as well. The biochemical assay, maternal assay, the cell-free DNA screening, which is the newest screening test for non-invasive prenatal genetic diagnosis. The fetal Rh status can be determined, the fetal gender, and paternally transmitted single gene disorders can be determined. And it works by amplifying cell-free DNA, basically. Okay, it also provides a definitive diagnosis non-invasively for the Rh status, the fetal gender, so those things. But the maternal plasma contains small fragments of the cell free DNA resulting from the breakdown of both maternal and fetal cells. So the normal amounts, which vary throughout pregnancy, are known and compared with those obtained from the maternal sample. And the test cannot actually distinguish fetal from maternal DNA, but it can accurately predict the fetal status by measuring the amount of cell-free DNA circulating in the maternal blood and comparing it with the known status. So the test is known to detect a rate of more than 99% for trisomies 21 and 18, but a lower rate for trisomies 13. Okay, so it's the accuracy there of testing for those genetic disorders. And therefore, women with positive cell-free DNA results are referred to for amniocentesis and also chorionic villus sampling to actually confirm those findings for just a little bit until we get more data. Now, fetal care centers that provides diagnosis, therapy, and support for families with an anomaly diagnosis and care coordination efforts. Nurses assist in navigating multiple appointments. Here is the antepartum assessment using electronic fetal monitoring. You probably have already covered this already. We're just going to do a brief overview. So the indications varies with gestational age. The goal is to determine if the intrauterine environment is supportive to the fetus. The non-stress test, fetal activity determination. So we apply an external fetal monitor for about 20 minutes. If the baby is less than 32 weeks gestation, we do 20 minutes. Greater than 32 weeks gestation, we do 20 minutes for 2 accelerations, 15 beats by 15 seconds. So you measure the accelerations if they go up 15 beats from the baseline and if they last for 15 seconds. And we need at least 2 of those in 20 minutes. Now, when it comes to a baby who is younger than 32 weeks gestation, you only need 10 minutes to evaluate them, and you only need 2 accelerations in a 10-minute period, and they need to go up 10 by 10 in order to determine that it is a positive or a reactive, non-stress test. If they do not meet that criteria, then you keep them on the monitor for an additional 20 minutes if they're greater than 32 weeks, and for an additional 10 minutes if they're less than 32 weeks. And typically we try to give the moms something to drink there or to eat that has sugar in it, or start an IV for the mom if she's dehydrated. We take a urinalysis to make sure she doesn't have a urinary tract infection, and rule out any other types of complications by doing a head-to-toe assessment to make sure that her blood pressure is not elevated, that she has not arbitrarily ruptured her membranes, etc., etc. So that, and take her temperature and pulse ox to make sure that everything is okay with the mom, while we are also doing the non-stress test here. Reactive non-stress test. As you can see here, I went ahead and marked the accelerations with these little gray markers there. You would look here and see that the baseline rate is actually at 120s to 130s, and it goes all the way up to 150s, all the way up to 170s over here, and all the way up to 160s here, and it lasts an extensively long time because remember, each one of these blocks right here represents 10 seconds. Non-reactive stress test, you can see here how the variability is not a straight line, but it looks kind of like this baby is in a sleep cycle right here, or that mom has had some type of medication or to sedate her because there are no contractions down here whatsoever. So it looks like the baby's in a sleep cycle there, but you can see that there's pretty much a straight line there with minimum variability, and you don't see any accelerations whatsoever. Antepartum assessment using electronic fetal monitoring with a vibroacoustic stimulation. So a vibroacoustic stimulation here is actually a laryngo voice box or a vibrator is what it is, and we use it to, it's called a fetal acoustic stimulation test as well. We use the sound and the vibration to stimulate the fetus if that baby remains asleep. We try to wake the baby up. So when we have a non-stress test that is obtained, a laryngeal stimulator is activated for 3 seconds on the maternal abdomen and the fetal head. So you palpate doing your Leopold's maneuvers to find the fetal head and put that vibrator right over top of the fetal head, and it may be repeated 1 minute intervals like 3 times. If no results, then we're actually going to go and do a biophysical profile right away. No long-term evidence of hearing loss for children followed for about 4 years. Okay, forgive that typo. They followed children who've had the FAST test for 4 years now and have found that there's no long-term hearing loss as a result of it. Reactive stress test after vibroacoustic stimulation. As you can see here, there was flat, and then all of a sudden you can see here how we're starting to see accelerations noted, which is exactly what we need. The antepartum assessment using electronic fetal monitoring contraction stress test. So a contraction stress test, the difference between the non-stress test and the contraction stress test is that the contraction stress test measures the fetal heart reactivity during the presence of contractions. And if we want to stimulate the mom's contractions, if she doesn't have them already, she can do nipple-stimulated contraction stress test, or we can start an IV and offer her oxytocin, which is a oxytocin-stimulated contraction stress test. And then, of course, we would do the interpretation. It provides a warning of the fetal compromise earlier than a non-stress test, if in that case, because if you see a contraction and you see that there is a deceleration present, then you know that that baby is lacking fetal reserve, whether it be a late deceleration is what you're kind of looking for if you notice late decelerations present there. Now, a physiological, so let me tell you something else about the contraction stress test if I need to. I think I've told you pretty much what I need to tell you. Physiological considerations in high-risk pregnancies. Careful monitoring throughout pregnancy. Women may feel less stress related to diagnosis. They may have a low self-esteem, guilt, frustration. They may alter their ability to attach to the fetus, and the nurse provides encouragement and support. Here we have letter A. That is showing you a negative contraction stress test with no late decelerations. And negative is a good thing when we're talking about the CST. And then the letter B, you can see that there are late decelerations. You can also notice and see that there is minimum, there's like almost no variability located. That line looks almost straight. That baby is in an ominous situation, and they need to go and do a C-section right away on that baby to make sure that that baby has stability afterwards and some pretty good APGARs. Nursing role in the assessment and management of a high-risk pregnancy. First of all, education, education, education. Education about the test and the self-care, planning, counseling for adaptations, assessment, planning interventions, support for testing procedures, and coordination of care. Here's a question. The volume of amniotic fluid is an important factor in assessing fetal well-being. Oligohydramnios and amniotic fluid volume of less than 300 milliliters is associated with what kind of fetal anomaly? And your choices are renal, cardiac, gastrointestinal, and neurologic. Well, let's talk about letter B first, cardiac. Cardiac would be incorrect because the amniotic fluid volume has no bearing on the fetal cardiovascular system. And gastrointestinal system, it's incorrect because gastrointestinal anomalies are associated actually with hydramnios, which is an increased amount, or an amniotic fluid volume over 2 liters. Okay, and then the neurologic, that's incorrect because the amniotic fluid volume has no bearing on the fetal neurological system. However, letter A would certainly be correct because it's renal. And remember that renal agenesis causes a decreased amount of amniotic fluid or oligohydramnios, because remember that amniotic fluid comes from fetal urine. Okay. All right, this is the end of this slideshow, and I hope that you have enjoyed this presentation, and I appreciate your time. Thank you.